So welcome everyone to the lunch symposium entitled Real-World Application of ENVARSUS XR, Transitions of Care, sponsored by Veloxis. And on behalf of the AST, I'd like to thank Veloxis for their continued support of the CEoT meeting. I do have a couple housekeeping notes before we get started. As a reminder, this is a non-CME program and credits will not be available for this event. Veloxis is doing session scanning, so if you didn't get your badge scanned on the way in, please raise your hand and the Veloxis team will come around to scan your badge. There will be a Q&A portion after the presentation. Questions can be asked via the question cards on your table or the microphone. And you will find a folder with an evaluation form at your table, so please take a minute to complete it. You can leave the form on the table when you're finished. So we have two fantastic speakers to introduce today. The first is Dr. Christina Klein, transplant nephrologist, former transplant fellow at the University of Wisconsin, and medical director at the Piedmont Transplant Institute in Atlanta, Georgia. And we also have Dr. Alexander Weissman, executive director of kidney transplantation at Advent Health Transplant Institute in Denver, Colorado. Today's symposium will include a dynamic case-based discussion in which they explore evolving treatment paradigms, including strategies to facilitate the safe and efficient transfer of care for kidney transplant recipients. So without further ado, I invite Dr. Klein and Dr. Weissman to the stage and to start this session. Thank you.
Thank you, Dr. Foley. So it's a real pleasure to be here with you today at lunch. I am so grateful to you for spending your lunch hour with us and hope that this will be an educational and also very interactive conversation. So for the first part, when we're doing the presentation, feel free to enjoy your lunch, but we do want to have a pretty robust Q&A at the end. So please be thinking throughout the presentation, what information, any questions or any comments, anything that you can kind of bring to the conversation as well. So I am Christina Klein, and I'm very honored to be presenting with Alex Weissman. Just a little bit of history. I was a general nephrology fellow at the University of Colorado, and Alex was a younger attending at that time, one of the two transplant attendings, and he is really the reason that I became interested in transplant. So I entered nephrology not thinking about transplant at all, and we did a 3-month rotation, and by the end of my first month, I already knew that I could not find a more fulfilling career than transplantation. And so I really credit you, Alex. It's such a joy to be up here on the stage with you. And Dr. Foley was one of my attendings at the University of Wisconsin, and it's just really good to see a lot of familiar faces here and think about how we all support each other. So in this talk, we're going to be talking about ENVARSUS, but specifically, I want you to think kind of broader than that about transitions of care. And what I mean by that is that if you, as the transplant program, if you're the nephrologist or the surgeon, how are you co-managing care with the local community physicians? And for kidney transplant, that could be the nephrologist, but it also could be any of the other subspecialists that the person has to co-manage their comorbidities such as heart failure or diabetes. So we really want to think about the collaboration between the community doctors and the transplant center. So this is, as Dr. Foley mentioned, a non-accredited promotional activity, and the program content was developed and approved by Veloxis Pharmaceuticals. Myself and Dr. Weissman have received compensation for this program and will present this information in compliance with US FDA regulations. So we have several slides with important safety information, and several of you in the audience are very, very familiar with this information. You could view it as repetitive. So what I want you to think about as we go through these slides, if it is information you already know, I want you to think about, how do I impart this information to my community doctors? So if it's the community nephrologist, if it's the endocrinologist, cardiologist, because everybody in those groups is interacting with these patients. And for example, when we talk about drug-drug interactions, that's a really important teaching point that we have for our community care providers. So first, for indications, ENVARSUS has 2 indications. It's indicated for prophylaxis of organ transplant rejection in de novo kidney transplant patients. But it's also indicated for the prophylaxis of transplant rejection in patients converted from IR TAC to ENVARSUS. Important safety information with regards to malignancies and infections. There is an increased risk relative to the general population of some malignancies, particularly post-transplant lymphoproliferative disease, as well as skin cancers. And then we all know in transplant that the infections are not, limited to bacterial infections, but also CMV, BK virus, fungal infection, protozoal infections. It's contraindicated in patients with a known hypersensitivity to tacrolimus. It's not interchangeable with other tacrolimus products, so the risk for medication errors. Again, I think with the topic of this meeting being transitions of care, this is probably the most important point on the important safety information slides, is that it is not interchangeable with IR TAC. So, the company, and there's a lot of information about if you're de novo dosing or if you're converting a patient from IR TAC to ENVARSUS, how this is done in a safe manner. But it's not only getting the dose correct, it's also educating the patient. You want to educate the patient on the time of day that they're to take their ENVARSUS, that they can't crush or alter the tablets in any way. So there's a lot of communication both with the patient, potentially the pharmacy as well, and all the information has to be relayed in the same manner. So the physician can't be telling the patient one thing and the coordinator giving them a different set of instructions. So really think about, how it's not interchangeable and how we can improve the safety, particularly if we're using it for conversion setting of, the change between the IR TAC and ENVARSUS. Same as IR TAC, ENVARSUS is associated with nephrotoxicity, particularly with supratherapeutic levels. It's associated with new onset diabetes after transplant, and our African American and Hispanic patients are at higher risk for this. Neurotoxicities, hyperkalemia, hypertension, and then speaking to drug-drug interactions and potential medications that non-transplant or non-nephrology providers might be prescribing, there's the risk of both the strong CYP3A inhibitors and the inducers causing either higher or lower levels of tacrolimus. So QT prolongation is another consideration, particularly with multiple medications. So you might have somebody, the obvious one is congenital long QT syndrome, but there are several antiarrhythmics used in patients with heart disease, and more of our patients have heart disease. So we have to be aware of the potential for a long QT, particularly with other medications that could potentially do that. Immunizations are best administered prior to transplantation. We avoid the use of live vaccinations after transplant, and even vaccinations that are considered safe after transplant may not be as efficacious once the patient is on immunosuppression. Pure red cell aplasia has been reported with tacrolimus. And then I have a hard time saying this word, so I'm sorry, but cannabidiol. I used to say cannabis, but there is the potential for a drug interaction with that. And with several states having legal use of marijuana, we want to make sure that we know these interactions and that we're communicating this appropriately to our patients as well, that the drug levels may be altered with cannabidiol. In terms of adverse reactions in de novo kidney transplant patients, the adverse reactions with the greatest incidence of over 15% included diarrhea, anemia, urinary tract infection, hypertension, tremor, constipation, diabetes, edema, hyperkalemia, and headache. And in the conversion patients, most common incidents were diarrhea and increased level of blood creatinine. So this is the last ISI slide, but to speak to use in specific populations, In terms of pregnancy, post-marketing surveillance reports in animal data show that tacrolimus may cause fetal harm. So we have to have really good preconception counseling with our patients that are interested in pregnancy. Same with nursing. Tacrolimus is present in human milk. So again, that's a conversation with the person that's interested in nursing with the transplant provider to discuss the risks and benefits and make an informed decision with regards to that. For females and males of reproductive potential, based on animal studies, ENVARSUS XR may affect fertility. Pediatric use has not been established, and in geriatric patients over the age of 65, there were insufficient numbers of patients in order to sufficiently determine how they respond to ENVARSUS in that particular population. Both in renal impairment and hepatic impairment, you can have increased levels of tacrolimus. So if a person has an acute change in their serum creatinine, for example, if they're hospitalized, it's important to know that their tacrolimus level may change. I think that for those of us that work at transplant centers and we get tacrolimus levels every day, that's no big deal. We just measure the level and change it. But where it really comes to effect is that if a person is hospitalized at an outside hospital and they don't have a tacrolimus level that comes back for 3, 4, 5 days, you know, if they have AKI when they're admitted or they have hepatic issues when they're admitted, they certainly could have supertherapeutic levels of tacrolimus during that hospitalization. Race, we know that African American patients in general require higher doses of tacrolimus to achieve therapeutic blood levels, and African American patients and Hispanic patients, as I mentioned, are more prone to new onset diabetes after transplant. So there is the Veloxis line there to report suspected adverse reactions. All right, so now that we've gone through the safety information, I just wanted to ask an audience question with show of hands. In general, how soon post-transplant do you refer a patient back to their community-based nephrologist? And Dr. Wiseman and I were talking before this session, and this question is a little bit vague because, you know, the question could be, how soon do you co-manage care with their referring nephrologist, or how soon do you release them entirely back to their referring nephrologist? So I'm gonna say maybe for co-managed care, how many of you refer at 3 months or earlier? How about at 6 months? At 9 months? 1 year? Longer than 1 year. Okay. And then kind of a quick show of hands, are there any programs that basically release patients to their local nephrologist at any point of time where they're not seen at the transplant center annually after that? Okay, so just my.
So what is your practice? If you were to describe it in detail, like how does a patient flow into and out of the Piedmont Transplant Center?
Okay,
Yeah.
so for our program, we essentially take care of everything related to patient care, you know, with the exception if they have an acute cardiac issue or anything like that, but any nephrology transplant care for the first 3 to 6 months. So we find that there is a varying level of interest with the referring doctors of when patients see them back. So some referring doctors want to see their patients at 3 months back. Some feel like 6 months is a little bit too early, but we encourage them to see their doctor at minimum by 6 months. And then we're seeing them at 9, 12, 18, 24, and then annually after that until they're released at 5 years post-transplant to their referring doctor. But there's a wide continuum. So what is your experience?
Well, it's very interesting, and I think that the show of hands really shows that this is a diverse and non-standard way that we take care of patients. And I love this meeting because it's all about innovations and technology and all the great things that can happen. And we've spent a lot of time looking at this HRSA roadmap that leads into transplant and access to care. There's like A through L on the stop, on all the bus stops or all the subway stops. The K to L on the far right was post-transplant care. Mm-hmm. And the fact of the matter is we should be creating this subway with many different stops along the way beyond that KL of the subway diagram, because we do have co-management, and we have different routes for different patients. So in our region, we basically have clinics that geographically spread up to Montana, Wyoming, where there's no transplant centers whatsoever, to deep into the four corners of Colorado. So those individuals need to get back to their lives, need to get back to their community, and don't want to be in a transplant center. So we have to have a way to communicate and refer back our patients in a safe way. And to do so, it really takes this co-management discussion to a really important level. I think the closer region, and perhaps most of your patients may come from Greater Atlanta, but then you have a lot of rural outreach clinics as well that you reach out to. And it's very similar. We have differing levels of interest and expertise throughout our referring practitioners. And if you think about our fellowships and our training and what they've learned and what they do, 10% of nephrology boards are focused on transplant nephrology. Probably 10%, if you spend 3 months in a fellowship, that is geared toward transplant within your nephrology fellowship. It's probably about 10% of your knowledge. So you basically are dealing with referring back to a community where that's 10% of their knowledge base. And we need to be able to really provide that kind of education. So in our center, we have kind of a dichotomous way of if it's a distant patient to a distant nephrologist, it's probably at that 3-month point that we are requiring communication and visits, where we'll do a lot of telehealth visits. We can talk about how the valuable or the gaps that exist with telehealth. I noticed that my telehealth visits are probably about 2/3 as long as when I'm in the clinic, So how much am I imparting and how much wisdom to the patient, how much hardwiring of understanding of their disease process is going on then? But most of our patients are now being transferred to the general nephrologist at the 12-month point, which leads to a very dangerous potential point where they don't land in the nephrologist's doorstep. And we'll talk a little bit more about that later. So, yeah, thanks.
I did love all the talks yesterday about remote monitoring, for example, just because, telehealth visits, when we first started doing it, we're depending on the patient to self-report accurately things like blood pressure, for example. And that's really important in nephrology, is your blood pressure controlled?
Yeah.
And just the idea of, if we are going to be able to provide care from far away, how to best do it in a way that most mimics the transplant center care, if they came that way.
Yeah. And I know many people in the audience are definitely working on trying to standardize this and try to learn a little bit more about how best to co-manage with their nephrology partners and how best to handle the workforce shortage that we're really facing. So they're busy. They may not want to see the patients as frequently or as soon after transplant. They may be less comfortable. There's a lot of issues about our workforce shortage as well as their workforce shortage.
Right.
Yeah.
All right, so I think it's been very exciting for me to be in transplant for pretty much close to 2 decades now, because I've seen a lot of the changes that have occurred over the last 20 years in particular. The first successful kidney transplant was in the 1950s, and in 1984, we had the National Organ Transplant Act passed. And this established the OPTN, for example, and the SRTR. In 2006, it was the Uniform Anatomical Gift Act, so that really helped to cherish the gift of organ donation for people that had decided to sign up as organ donors before passing and to protect that gift. In 2013, the OPTN approved the new CAS based on KDPI. So we saw the introduction of KDPI. We also saw prioritization for high PRA patients, as well as the use of A2 and A2B kidneys to be recipients. In 2019, the Advancing American Kidney Health Initiative was introduced. And I think that there was, the exciting part of that for me was that there was kind of a renewed focus on referring patients for kidney transplant. So dialysis not as an end destination, but really, again, looking at the value of kidney transplantation. More recently, in 2021, the OPTN kidney allocation system policy update that really changed the landscape in several areas of the country, including my own. Before the new CAS policy update in Georgia, people were waiting in general, if they were O and B blood type, 8 to 9 years for a deceased donor kidney offer. And we in Emory and Augusta, we are working really hard to maximize our utilization of deceased donor kidneys, but still it was, a very long waiting time. And now I'm proud to report that for those same blood types, our waiting times are closer to 3 years. And that changed in the reverse for some areas of the country. So it was definitely a huge change in our country. And then finally, the Comprehensive Immunosuppressive Drug Coverage for Kidney Transplantation Act of 2020. And this really helps to ensure Medicare coverage for immunosuppressive drugs past the prior deadline of 3 years post-transplant. So I think that slowly but surely, we're trying to increase access to transplant. We're trying to address equity issues in transplant, and also the long-term care of the kidney patient to make sure that once they're transplanted, they can enjoy the transplant, remain healthy for longer. So kidney transplants, year after year, we're transplanting more people. And I think that this is really amazing, the number of transplants that we're doing. So in last year, we achieved, about over 27,000 transplants, so about 21,000 deceased donor transplants and over 6,000 living donor transplants. And the number of deceased donor transplants has always exceeded the number of living donor transplants. Number of living donor transplants staying relatively steady in terms of numbers, going up and down a little bit year to year, but the number of deceased donor transplants increasing, which is very encouraging. But we all know, on the flip side, that the number of people that need a kidney transplant is 4 times greater than who we're actually transplanting on an annual basis. And for example, when people would come to us when our waiting times were 8 to 9 years, if they were older and had comorbidities, we could list them, but the chance of them actually getting a kidney transplant was less than 20%. It was much more likely that they would have an illness or death that would remove them from the wait list rather than getting a transplant. On the bottom of the slide, you see the number of prevalent kidney transplant patients in the US also climbing, with about 250,000 kidney transplant patients in the US currently. And the one thing about kidney transplant is that a significant number of people on our waiting list are actually retransplant candidates, right? So if we have 500,000 or 250,000 people with kidney transplants functioning today, what can we do to maximize the long-term graft survival so that the time between their first, second, and third transplant is greater, and that we can increase the number of prevalent patients? So the immunosuppression regimens in use today, primarily tacrolimus MMF based. So at the top you have tacrolimus MMF plus steroids, and in the red line, tacrolimus MMF steroid-free protocols. So when we're thinking about the transition of care, in the first several months to up to probably a year post-transplant, we really are prioritized on immediate care priorities, which is, making sure that we're maximizing graft function. Immediately after transplant, we might have DGF. We have to manage their DGF well. Hopefully they remain on dialysis as little as possible. Really identify early cases of rejection and treat them appropriately. Prevent acute rejection with our induction and maintenance immunosuppression protocols. And then prevent or early detection and treatment of opportunistic infections such as CMV and BK virus. Then long-term priorities, we're thinking more like 6 months, 1 year, and longer after transplant. This also really, really helps and is important in maximizing graft function and survival. It's more of I think of it like a 5K, I'm running a half marathon tomorrow, so I'm pretty excited about that. But like the immediate care priorities is like the 5K, and the long-term priorities is the marathon, right? Slow but steady. It does make a difference. You're achieving something at the end, but it's slow and steady. So we have to mitigate the risk of adverse events such as infections still, but also malignancies, for example. Skin cancers. I've had some patients with awful experiences with skin cancers that we probably could have done a better job at explaining the risk of skin cancer to them at the time of transplant and changing their behavior early before the problem really set in. Managing other underlying disease and comorbidities. I'm still amazed at how many people that have diabetic nephropathy as cause of their kidney disease don't realize that diabetes can cause graft failure in their transplant graft. And so even if it seems very obvious to you, it may not be obvious to your patient, and that may be the motivation that they need in order to manage their diabetes, get under better control. And I will say that also in my area of the country where this is a big issue is that one of the things that we did do on the pre-transplant side was for insulin-dependent diabetics, we required them to have documentation that they had somebody other than their nephrologist prescribing insulin. Because many of them just had their nephrologist managing their diabetes, which could be fine, but we really wanted them to have somebody, if the nephrologist wasn't managing them right after transplant, you know, it'd be much better for them to have an established care with a PCP or an endocrinologist. All right, so factors that can threaten long-term graft function and survival, we kind of separated them in the immunologic factors and the non-immunologic factors. And some of these are factors that can be modifiable over the course of the transplant function, and some are non-modifiable. So for immunologic factors that are non-modifiable, at least after the graft is placed, is HLA mismatch, prior transplantation, their PRA going into transplant. But the things that are modifiable are immunosuppression. So it could be the choice of induction, it could be the choice of maintenance immunosuppression, it could be just not achieving the therapeutic drug levels because the patient isn't getting labs and the coordinator doesn't have time to call them to encourage them to get their labs done. And then non-adherence is a big factor as well. And I've really learned a lot about adherence through some of the other talks that I've heard on this. And a lot of non-adherence isn't intentional. It's not people being like, well, I got a great kidney, but now I want to destroy it, you know, just to make you upset, Dr. Wiseman, you know, I'm not going to take my meds. A lot of it is a lack of literacy, potentially, education, just going through things over and over again, repetition. Like, we know it so well that it's not like a foreign language to us, but for a patient starting immunosuppression, it's all new to them, and different people have different levels to learn about their immunosuppression. So I love our PharmDs. One is sitting right here in front of me, but they basically have a process where they assess a patient's comfort level and reliability with filling their pill box and understanding their medication. And if a patient has it by the first visit, they're done. You know, they check in with them at certain time points, but you know, they're comfortable with that. But if a patient isn't ready, they'll see them clinic visit after clinic visit and maybe some in between clinic visits in order to really get it down. So this slide kind of just shows that there's this collaboration between the transplant centers and the community and primary care settings. And I think that this is definitely part of the pre-transplant care and the post-transplant care. And when Piedmont was building our transplant program, you know, we used to do about 150 kidneys a year, now we're at 350. One of the ways that we really did this, or one of the things that we focused on in order to have growth but maintain outcomes is availability. So our physicians, we give our cell phone numbers out to referring doctors all the time. And we just say, call me, text me. And the deal is that if I'm here at CEoT, I don't just not answer my phone or my text. I refer them to whoever it is that can help them. And I think that's super important. So if you want to have a good relationship with your community providers, you have to be accessible, either Epic Chat or texting, not patient information, but like, I need to talk to you about somebody, picking up the phone, answering your phone. It's not one thing that's going to work for everybody, but you have to be accessible. So in terms of transition to long-term care, here's a question and one answer. So the number of renal transplant patients thriving long-term is increasing. Despite the resources staying relatively the same, how do you see co-management of transitional and long-term care improving? So one physician answered this: in an ideal world, we want to get a referral at the right time before the patient starts dialysis. We want to move them to transplant, get them stable, and then send them home back to the community nephrologist. That way, I can spend my time taking care of the next transplant patient. So kind of what would be your answer to this question, Alex?
Well, I look at this response and I see what I think we would all hope for is that there's equal competencies and equal access to post-transplant care everywhere, and that once the transplant center has kind of wrapped people up in a bow and they're stable and they're ready to go, at time X, they're going to be ready and everything is going to be fine. What I think needs to be kind of thought of, and especially in terms of, in the context of cutting edge of transplantation, is just all those tools, those IT tools that we dream of to be working so functionally in the pre-transplant side of things, where we're managing our wait list a little bit more efficiently, we're getting our patients through and identifying patients who can be expedited and having conversations regarding living donation. I think that on the post-transplant side, it would be wonderful if we could have ticklers in our EMR system for, we set ranges for when we want to be notified of abnormal labs, that all of our labs come to a central resource, that there is two-way communication, bidirectional communication between the community EMRs that they use and our EMRs that we use, and be able to act upon the same information in the same time frame, where we're not acting upon fax orders or fax labs, who's reviewing what, when. Those are the things that I would hope long-term care could improve in general. I think what we end up doing right now is, if you send off a patient and they are going to be on a monthly lab schedule, it's really an active act by the transplant center to know that they've actually had those labs drawn. It would be wonderful if we could have ticklers that just remind, instead of doing reports, that we're acting upon it, that it's a passive distribution of labs have not been done, call, have a much more seamless way of managing patients. Because once it moves away from a transplant center, or there's multiple cooks potentially, then there's multiple areas where you can fall through the cracks, basically. Right. And so how do I see co-management? Ideally, there's education. Those are the dreams, right? That's like the EMR dream. But I think the co-management structure is one that I would hope has identified transplant champions within each program, APPs that have a broad, defined role of how to manage patients in those practices. I think it's the obligation of the transplant center to educate each referring practice in a way that you're ensuring that they are performing the same task that you would hope that they would be performing, basically. It's a big ask, and I think that what ends up happening is you have multiple referring practices with multiple referring experiences, and our outreach, so when you go on when we go out and meet our community, and we're trying to essentially expedite referrals and speed up that referral process and talk about how there should be bidirectional communication about stress tests, echoes, how are we getting this patient on the list? Are they active? Are they inactive? Et cetera, et cetera. We don't have those same conversations about post at all. Here's what we do, here's our protocols, see you later. Right. So it really should be a little bit more bidirectional.
But by meeting your referring nephrologist and putting a face to the name, and just showing that you're open for that conversation, you probably do invite dialogue on the post-transplant side. All right.
So basically, I think that this leads into the other conversation, which is really that there's now an incentive for our nephrology colleagues to really focus upon transplant as the first option in chronic kidney care. There's a number of models that are now in development and in practice. The Kidney Care Choices model is a voluntary model in which Medicare beneficiaries within a practice can be enrolled, they're followed, they're managed as if they're managed in a capitated payment system similar to a dialysis capitated payment system, only in the CKD 4-5. And one of the big pushes is to see that they have optimal starts, they have appropriate timing of dialysis, but they also are appropriately evaluated and appropriately referred and educated about living donation, looking specifically for preemptive transplant as the goal. As a reward for that behavior, there is an incentive plan for those nephrologists who see their patients through to transplant, such that for every year of survival post-transplant, a transplant provider will receive $2,500 bonus at the first year, $5,000 bonus at the second year, and $7,500 bonus at the third year, which means it's very important to not only the patient, but now fiscally important to the general nephrologist managing the patient to see that patient through to an optimal outcome, at least medium-term survival. Now, we as transplant centers, we have to act as partners in this. By definition, the KCC is a partnership between nephrology practices and transplant providers. We manage those patients probably the same way that we would always manage patients. We don't see that bonus, but that's a topic for other discussions, is that we help them manage to the point where these patients are successful and that the referring providers understand the value both professionally and financially in terms of transplant success. So I could pick it. All right. So how does this actually play out post-transplant? And I think that every transplant center has to have its own strategy, but there's some universal principles that are in place that we really need to say, this is the information we need, this is how we need to communicate. I think before transplant, during that early phase, as patients are coming through, they need to know that there is a multidisciplinary team that's following them and that they will return to their community nephrologist at some point X. I think that early post-transplant phase is where we're all in the business of making it happen and making it successful. We don't want to turn over patients who are in the throes of complications, and so we may be hanging on to some, but then during that transition, and again, that could be as early as 3 months, it could be as late as 5 years, you never know, but that transition period really has to be very well defined and accepted by the patient, the nephrology practice, and the transplant center. Everybody has to know what the rules are. And the rules really are, for example, in our program, the rule is that at 1 year, we expect that you have called your nephrology provider and made an appointment within a 3-month time. We will be seeing you at the 18-month window to check in on you to make sure, and we'll be ordering labs and we will order your medications, which tend to be like a 1-year refill. So we've essentially set them up for a 1 to 2 year success with a hope that there's going to be someone that picks up the slack at this 15-month point. And then after that transition happens, we have to be able to provide that information of what we want information, when do we want to be called, what is their responsibility, and who will be managing the labs, who will be managing the abnormal labs, who will be CCing whom, right? Is it the transplant center doing it? Is the nephrology practice doing it? I think all of these things form the most critical window, which is that handoff that I think all programs, and be interested to hear how other programs handle that handoff period, really have to nail that time frame down. So this is just an example of shared responsibilities that we would have during these time periods. You see on the left-hand side is what the primary provider may be responsible for that, whatever, 3-month, 1 year, whenever those patients are turned over. And then when do you call back? When do you have a transplant center re-engage or co-manage? And so, as you can see in the left-hand column with renal function, immunosuppression management, infectious disease screening, cardiovascular disease management, malignancy screening, there is a job to do, and then when there is an abnormality, how much responsibility and how much education is there for those providers to manage acute kidney injury? Probably pretty good. To manage BK virus, a little bit more hit and miss. Notification about medication formulary changes and medication drug interactions. These are things that come and go from individuals' knowledge base, and it changes over time. Think about what we've had with Paxlovid over the course of the last few years and how this really did not get to the general nephrologist in nearly the time frame that it should have in terms of drug-drug interactions and how best to manage that. There's always people falling through the cracks, and as recently as 2 weeks ago, I had a 74-year-old with a tacrolimus level of greater than 60 because of it. So these are things that unfortunately we need to make sure that those goals are really well defined and continue to be reiterated. So this, I guess, is a question for both audience to think about. Like, how do you help your general nephrology colleagues? So I've just described some scenarios where it is a Swiss cheese effect. If you're co-managing, then somebody might not be managing anything, and someone might be managing the same thing at the same time. How do you avoid Swiss cheese? And then when something bad happens, how do you best allow the community providers to be ready and engaged? So do you have strategies at Piedmont?
Right, so as we were preparing for this talk, I just thought that we have some, but we could probably do better.
Yeah.
So when we release our patients at 5 years, we really want our referring doctors to know that we're there in case of certain things happening. We definitely don't want them to feel like the patient can never come back. But we provide the patient as well as the referring nephrologist the same information. And basically we outline some possible scenarios where we want the patient to come back to us. For example, pregnancy, if they are diagnosed with cancer, if they have a serious infection, if they have AKI, we kind of outline what we mean by that. Proteinuria for a biopsy. So we do give them a list of things like, if this happens to you, please, we want to see you again. But it doesn't cover everything, like Paxlovid, for example. Like, how do you disseminate that information on a grand scale to not only nephrologists, but anybody, the primary care doctor that could be feeling like they're doing a great thing for that patient by prescribing it.
Yeah.
Do you target the patient first just because they're going to be seeing so many doctors? What's the best way to get that information out?
Yeah. So in a similar way, I think that we give a kind of a discharge letter or a letter back to the community whenever we are referring back at that critical period of time. And there is a much more watered down but very user-friendly version for the patient. The patient gets a graduation letter. The referring nephrology practice gets a summary letter of what the expectations are with callback numbers. So I think that some of the things that fall through the cracks are phone numbers of who to call when, both of those. And so I like to kind of revisit both the graduation letter for the patient and the referral back letter to the nephrologist. I think that in the era of EMR, I know that in our practices over time, we've become a little bit more lazy in making sure that those letters are sent out and are stringent about what we mean, to the general nephrologist. And oftentimes, what happens is that if you have 5 providers in your clinic, 5 providers write a letter in a certain way. There's information that's not codified or not written in the same way. It really needs to be a codified, and it's easy to send the last letter of the last visit to say, okay, here's all the information you need, go forth. But so I think that there really needs to be a comprehensive discharge or plan for the nephrologist. So one of those aspects that we actually came up with, we both are deficient, I would say, in our referral back information is how best to handle different medications as it comes in, right? So do we tell patients what to do in cases of running out of medications? We hope that we've provided them the right information, same with the nephrologists. One of those could be in probably the most important medication we have, calcineurin inhibitor use, and how best to manage different formulations. So ENVARSUS is a different medication than tacrolimus. It is essentially a medication that is broken down into nanocrystals and then sprayed onto a matrix that creates a tablet rather than a capsule. So it's a different type of pill for the patient. So it's a different medicine than Prograf. It is tacrolimus in a different way, and it's delivered in a different way that allows for a different way of dissolution, absorption, and bioavailability, which will be shown on the next few slides. This is just a schematic of how in scintigraphy, you basically can see drug go through the GI tract and where it is absorbed and where it remains. And most of tacrolimus in Prograf form or capsule form will be broken down and absorbed in the early gut. Whereas with ENVARSUS, you have an extended release where there's less metabolism and more even absorption throughout the entire colon. And this results in pharmacokinetics, which actually look much different, looking at Prograf versus ENVARSUS. This essentially is the Prograf pharmacokinetic curves, looking at two different varieties. One is the rapid metabolizers, or the CYP3A5 STAR1 varieties. So there are genetic polymorphisms that allow for different metabolism of tacrolimus. And so the rapid metabolizer, if you control for the trough level, you will basically see that in settings of rapid metabolism that they will have a higher, like a 34% in this example, Cmax compared to the non-expressors or not rapid metabolizers. This does not take the same form in terms of ENVARSUS, which again is a slow, steady absorption profile over time. So you do see a lower Cmax for the same trough level. You do see a higher AUC, and we'll talk a little bit about just dosing strategies, but you basically see a lower Cmax, and importantly, rapid metabolizers versus non-expressors have about the same Cmax. Fortunately, we've got a fair amount of experience over time with phase 3 randomized controlled clinical trials that show equal or non-inferior efficacy in terms of biopsy-proven acute rejection, graft failure, death, loss to follow-up, and the composite endpoint. This is one such study looking at comparison between Prograf and ENVARSUS in the de novo setting, but the same holds true in a conversion setting. And then this just speaks a little bit back to that issue of expressors versus non-expressors of the CYP3A5 STAR1 profile. So for that same dose, or for that same trough level, you don't get the same peak, and you actually need less exposure of drug because of that higher AUC that you see. And so for a comparison of blue to red, so ENVARSUS XR to immediate release tacrolimus, you can see that the daily dose is about 20% less whether you're an expressor or non-expressor. For people who are educating the community nephrologists, I think that talking to community nephrologists about what ENVARSUS is and how it's different, one aspect is the pharmacokinetics and the dosing differences. The other is just what the tablet looks like and the dose, the milligram strengths. The fact that it is a once daily dose that it should be taken on an empty stomach. And interesting, I think this is an important point for the patients to know, is that if they miss a dose at some point throughout the day, anytime that they're awake during that day, they should be able to just take their dose. So up to 15 hours, if they've missed a dose at 8 a.m., they should be able to take it up to 11 p.m. that day. And the advice is not to double dose, but to simply take your dose. If you miss it up until nighttime, you just missed your dose until the next morning.
All right, so we're going to go through a very quick patient vignette just to talk about use of ENVARSUS and then some dialogue between the transplant center and a community nephrologist. So Peter is a hypothetical patient. He's a 54-year-old African-American male. He's full-time employed project manager with a commercial insurance company, and he's under the care of his community nephrologist. So he was diagnosed with ESRD. He started dialysis 3.5 years ago. And after being on the wait list for 2.5 years, he received a deceased donor kidney transplant. So he was placed de novo on ENVARSUS as part of his immunosuppression regimen. So with the use of ENVARSUS de novo, the way that his dose was calculated was using 0.14 milligrams per kilogram, and we're assuming that Peter is 91 kilograms. This equals 12.74 milligrams once a day. The ENVARSUS tablets that are available, 4 milligram, 1 milligram, and 0.75s. So the team decides to round up to start ENVARSUS XR at 13 milligrams once a day. So he's going to get 3 4 milligram tablets and 1 milligram tablet. The prescription is written and he's educated at the time of transplant on administration, so everything that Alex just mentioned. And then his tacrolimus whole blood concentrations, a 24-hour level, is measured at least 2 times on separate days during the first week, and then after dose changes. Of course, paying attention if he started on any new medications that may interfere with his tacrolimus levels, cannabidiol, or any change in kidney and hepatic function, as we mentioned earlier. So this shows, again, just to be very cognizant that there are going to be times when you need to measure the trough levels of tacrolimus more frequently, even if a person had been in steady state. And the time to achieve a tacrolimus steady state is approximately 7 days, either after initiating or changing the ENVARSUS XR dose. So we're now currently at month 13 post-transplant, and he's under the care of his primary nephrologist with some conversation with the transplant center. So he is stable. He went back to work at his insurance company. At his last checkup, his creatinine was 1.1, and his tacrolimus trough level was 7.9 nanograms per ml. And his transplant program has specified that at this point post-transplant, their goal level is 4 to 11 nanograms per ml. So he goes to the pharmacy and he wants to refill his prescription for ENVARSUS, and he's told by the pharmacist, I'm sorry that your insurance declined to cover ENVARSUS, but don't worry, just talk to your nephrologist and he will switch you to a different form of tacrolimus. So, Alex, what do you do when you hear this scenario from your patient?
Well, this is kind of one of those things where we're here at this cutting edge of transplant meeting, and we're still struggling with the basics of getting our patients medications that they've been prescribed. And so to me, I get very frustrated when I hear this. My coordinators get very frustrated when we hear this. And I think that what ends up happening is that we other than getting frustrated, we basically want to proactively try to help prevent this from happening. Do we give enough advice to our patients before transfer of care, for example, to warn them of this possibility? Probably not. Think of all those things that we talk about throughout the course of the year that the patient might be learning about their transplant. How much is focused upon prior auth and medication issues? So something to think about in terms of our education. So when I hear this, of course, I call my friends, which are my coordinators, my PharmD, and they obviously have resources that they can implement at our transplant center to try to help this scenario.
So Peter really feels strongly. He's been on ENVARSUS since he was transplanted. He doesn't know first where to turn for help. So he does, because he's back to the care of his local nephrologist. He contacts his local nephrologist, and she says, I'm so sorry that you're having coverage issues. I'll just switch you to a generic version of tacrolimus that's covered by your insurance. So the question is, how often do you find that patient and colleagues, including social workers, are lacking information that could help in this situation?
How often?
Yes.
Unfortunately, so little vignette. So I've basically had, even when you do things right, sometimes you do things wrong. So we had a patient this is just 2 occasions last week. I had 2 scenarios. One was an individual that was 24 years old. He had been transplanted, he was back for his 2-year visit, basically. He had been on the waiting list for 5 years, received a deceased donor transplant, and he was placed on ENVARSUS, mycophenolate. He was doing fine. He left home finally. He went to work finally. He was underinsured but made money. He lost Medicaid. And he, at his 2-year appointment, after our medication refills had run out, was told that he was not able to have medications filled. So appropriately, he actually called our transplant center. We contacted our PharmD. Our PharmD sent him a form to fill out that he would be able to get a 30-day free supply while we work through these issues. And he works with his phone. He doesn't have a printer. He wasn't able to download it. He wasn't able to fill it out. He didn't do it in time. He lives away from his family, his parents now. His knowledge base or his capacity to handle that situation didn't work out. He turned to his parents. His parents ended up spending $400 on medications for the month, and all three of them were sitting in the clinic with me last week. So even when you do the right things, you sometimes don't always solve the problem. I think that what ends up happening is that we need to make sure that we as centers, so the question is, do the social workers, do our pharmacists, do our nurse coordinators all know how to handle the problem, and also how to handle the problem for the given individual? And so to just kind of keep those issues in mind. I'll save my other vignette for later, I think.
I do have a story about social workers, and when people in Atlanta were waiting, or in Georgia were waiting 8 to 9 years for a transplant, they were very close to their dialysis center. Their dialysis center is their family, and many of them had long-term relationships with the social workers. And one of the things that we have discovered is that a lot of times the patients will reach out to their dialysis social worker for help when they encounter this situation, who in general are not armed to handle this situation. So we really spoke to the need for our social workers, our transplant social workers, to have a strong relationship with the dialysis social workers so that they knew who to turn to help if the patient turned to them first. All right, so ENVARSUS XR is, again, not interchangeable with other tacrolimus products. And so the referring physician says, I'm considering switching a patient from ENVARSUS XR to generic tacrolimus, but I've been doing my research and I find that it's not just a straightforward one-to-one conversion. So she calls the transplant center for advice, and the transplant physician says, you're correct, it's not a one-to-one conversion. You could prescribe generic tacrolimus, but you need to know the correct dosing to do that, and it will require additional medical and laboratory tests for monitoring. So what does communication about immunosuppression therapies between kind of the local and the transplant providers look like?
Yeah. In particular, when we're talking about this transition, or from tacrolimus, immediate release tacrolimus and ENVARSUS, where you have to do dose changing, once a day, 20% less total daily dose, I think most general nephrologists catch on, or they can do enough research and reading about this to know enough. It's when they are faced with barriers that they kind of give up a little bit quicker. So my other vignette that I was just thinking about, again, happening this past week, literally, I thinking about this talk and thinking about having this discussion, it was amazing that within 48 hours of coming to this, prior to coming to this meeting, I had both this individual who lost Medicaid and then a physician who I've known for 25 years who is very interested in transplant and very willing and interested in seeing his patients back as co-management or independent management of transplant care. He called me up and says, I'm having trouble getting the right dose for this patient. I have them on tacrolimus 0.5, and I keep getting a level of 4, and so I put them on 0.5 and 1, and then it's a level of 11. What do you do if you keep shooting and ping-ponging from high, low, despite these low doses? And I said, well, I gave him some suggestions. I said, had you looked at ENVARSUS as a potential medication? Oh, he was on that before, but you don't understand what it's like for us. We have to deal with these prior auth issues, and it didn't work out. So even in the lack of that, he was fully aware of the mechanism and the management of the drug differences, but once given a problem that was a barrier to refills, it really became something that he acknowledged that was a problem. So it was, unfortunately, so what does communication look like in that circumstance? I would love to be able to go back and say, yes, our referral back letter and our referral, our graduation letter explicitly describes, please contact, we want to make sure we can help, that sort of thing.
All right, so the referring nephrologist says, Peter, I will prescribe you generic tacrolimus, schedule you for additional in-office medical and laboratory tests within the upcoming weeks. Peter says, politely, but he's frustrated, talk. I'm stable on ENVARSUS XR. I like my once daily medication. I'm back to work full time. It's really difficult to get, twice a week labs and fit in more medical visits. So how often does the patient's lifestyle or personal choice play into your decision-making process?
I think we should all be paying attention to patients' lifestyle and their choice. I think that patient-reported outcomes are hugely important, and I think quality of life is what we do this for. We want our patients to achieve normal, and if that means that something that they're comfortable with and that they understand and that might be a simpler regimen for them, I think that you have to make every effort possible to achieve normal.
Right, and I'm sure there's many people in the audience that take medications. If you've been on a stable medication for years and years and then suddenly faced with a dose change that changes your regimen, that is irritating, annoying. You want to be able to continue your therapy. So the physician says, I understand, please, Peter, contact the transplant center and the manufacturer's assistance program. In the meantime, I'll talk to your insurance company. And he says, thank you, I will do that. That really puts the patient kind of in the middle, right? So they're ping-ponging between the referring nephrologist, the pharmacy potentially, maybe the insurance company, and the transplant center. And it just speaks to the frustration that they could have in that process. So just for a moment, just wanted to talk about Veloxis transplant support. It's going to be known as VTS, that can provide patient support to assist with the medication access. So very easy to access the Veloxis transplant support. The phone numbers are there. There's veloxistransplantsupport.com. If the Veloxis folks could kind of raise their hands, where are you all sitting? Kind of in the back left table over there. So if anybody has a particular patient question or concern, or just you have support related issues at your transplant center, please feel free at the end of the talk to go speak to them. But there's benefits of investigation, prior authorization. There's a 30-day free trial. And then if your patient has commercial insurance, they may be eligible for a $0 copay card, as well as a bridge program for people that are experiencing a temporary delay in coverage. So with Peter reaching out to his transplant team and VTS, he was able to coordinate with his doctor and then get his ENVARSUS approved and remain on that medication. So is there anything else that we could have done to have a better outcome for this patient?
Again, I go back to just how well are we providing information to patients? How well are we providing information to nephrologists? To revisit our protocols and our process and make sure that it probably includes a little bit more about the potential for loss of drug accessibility and phone numbers to call, and to make sure that that's front and center in terms of the same things that we discuss in terms of BK screening, malignancy screening, et cetera.
Mm-hmm. I like to think of us that since we do discharge our patients, medication assistance is one of those things that I do feel like the transplant program, both the physicians and the social workers, should be very proactive about accepting that as our responsibility to help patients navigate through that.
Yeah.
Because like you said, I feel like if I was a referring nephrologist, not having the comfort level, it's a bigger barrier, and we're already familiar with it, so I do feel like that's our responsibility in transplant.
So just a final few things just to walk away with in terms of utilization considerations that we could make sure that we convey to our nephrology colleagues is that that we may need to use a little bit more care in the geriatric population. So when doing those calculations, and aim on the low side rather than the high side of that range of calculations when you do the weight-based dosing or the conversion dosing. It is obviously broken down by the liver. If you have severe liver disease, there's probably going to require a lower starting dose. Monitoring of renal function is recommended, but anything other than severe hepatic impairment, there's not a dose recommendation change to be made. And then finally, considering the fact that many individuals of African American race are of the high expressors of the CYP3A5 star 1 polymorphisms, you may have to consider that in terms of higher dosing strategies. Similar side effect profiles, as you mentioned earlier on, as tacrolimus-based therapies. We always have to worry about hypertension, post-transplant diabetes, and hyperkalemia, all require active monitoring in a similar fashion. And then finally, I just really want to thank everybody for coming. This is the last slide. If there are other comments or concerns, we'll be happy to answer questions. And if you come up to the microphone, great. But really, the bottom line is we've had substantial success. It really is amazing, 40% more transplants over the past decade or so. And we keep pushing and trying to improve graft survival rates. We're trying to improve access. But we really have to keep thinking about the lines along the subway beyond the first year of transplant as far as ensuring long-term survival. And that really involves our nephrology colleagues. Thank you.
So in particular, if anybody has any kind of comments on what they've done at their program to improve communication between the transplant program and the referring physicians or patients, would really love your input. Drew.
Hi, Drew Silverman, 30-plus year transplant pharmacist and 2-time kidney recipient. I think one of the things that I constantly hear at these meetings is that non-adherence is a patient issue. And I just want to remind people that a lot of the problem is how we communicate instructions to patients. And you pointed out that a lot of this is accidental, and I think that's part of the issue, is in the hospital setting, if you give a verbal order, the nurse is supposed to read it back to you to make sure that you got it right. We don't have anything like that when we call and tell patients what to do over the phone. A lot of times we leave them voicemails, and we don't even get to confirm that they understood what we're being told. And then when you add referring doctors to it, now patients are confused about who they actually should talk to when they're having issues, because they get mixed messages from us. And the one other thing I wanted to comment on with the medication issue is I don't know if we do a good enough job. We probably do at the time of transplant, but at the annual visits, reminding patients that at the beginning of the year, if they have new insurance, or even if they have the same insurance, they may need to get another prior auth for their medications, and they should be prepared for that at the beginning of the year, not when they're running out of meds and they're panicking to try and get that done.
Thank you very much.
It's really good comments, because I think that we are so busy focusing upon so many other things in that visit. And I will say, my annual visits, sometimes I run out of things to say in a stable patient. And I think that what we really need to do is make sure that we're hitting upon some of these hidden issues that can really cause problems.
I also like the idea of timing it, Drew. That was a great suggestion. Just because I find that if we routinely incorporate something at certain time points after the transplant, we're more likely to cover it, and also involving our PharmDs, just because they do see people at certain time points after transplant as well. Any other comments or questions?
I think we may
All
be
right,
good.
great.
Thank you for attending.